Cardiology Update. Viewers, listeners, and readers, my name is Dr. Chadi Alraies from Detroit Medical Center in Detroit, Michigan, United States. EuroPCR was full of great interventional coronary as well as structural interventions, as well as data-breaking trials. We're going to go through a top 10 takeaway from EuroPCR. Again, my name is Chadi Alraies. Let's dive into it quickly. The first trial is Design DBS trial. This is a trial looked into a very new, innovative way of looking into a new scaffold of stents compared to the traditional polymer, where these stents are coated with three drugs. It's one of the sirolimus and also the argatroban and rivaroxaban. This is an innovative way to look into the target lesion failure. So basically, this trial is just looking at the target lesion failure in compared to traditional or standard of care. And indeed, they show that in a patient who received this new innovative stents, they have a lower target lesion failure. Again, this is looking at the efficacy at only one outcome, doesn't look into any other clinical hard endpoint like a pre-procedure MI, complication, or thrombosis down the line. But it was safe, no thrombotic lesion, but has associated with lower target lesion failure. Good study. I recommend reviewing it. But again, I think we still require more data to implement it in clinical practice. Going to the next one. The second trial is a structural trial looking into the MyVal TAVR or TAVI. This is a new scaffold for very large annulus or very large valves. Some of the patients that we have to oversize even the largest size self-expanding or balloon expanding TAVRs. But this is coming to serve that cohort of patient who has a very large valves or very large annulus. The trial name is called Landmark, and they evaluated both the safety and efficacy of the valve, and they followed the patient for 1 year, and indeed it showed that this is favorable in terms of sizing, peripheral leak, as well as the bleeding risk was also favorable. Again, a new option, not in the market yet, new option for patient with large valves, areas that require large transcatheter aortic valve intervention. Third one is the Notion 2 trial. This is a structural trial looking into the outcome of TAVI compared to SAVR in patient with low risk and younger than 75. Again, this is a 1 year follow-up looking into hard clinical endpoint, pre-procedure failure, as well as MI and death. Indeed, showed that TAVI is comparable to SAVR in this cohort of patients who are low risk and younger than 75. There is a notification or it is an alert from the investigator that patient with bicuspid valve are they were not classified, or they had to be careful in this cohort of patient, again because of the aortopathy. And this is a very important point to bring here. TAVI definitely has been used in bicuspid, but all what we have is registry data and also some patients who are included in the low risk TAVR trials. Some of them were bicuspid. Again, did not have aortopathy associated with it, because obviously this patient will go for surgery, but we don't know how this patient will behave down the line. Usually oftentimes they are younger. Two, they have some sort of aortopathy that can develop down the line, so we don't know how to follow them and what we'll do if that happens, meaning dilation of the aorta. And third, in terms of the geometry, most of the time the calcification that affect the leaflet and the cusp in the bicuspid valve is really different than the tricuspid. So in terms of circular, it becomes more like an oval shape or a different geometry. So we don't know how this scaffold or balloon expanding or self-expanding valve will behave down the line in this cohort patient. Again, very important study looking into low-risk patients who are younger than 75. 1 year follow-up. Definitely we need longer follow-up to see the durability of these valves. Going back to the coronary is Orbiter 2 trial. This is a sub-investigation of or analysis of the trial. This is where they follow the patient to see the correlation between the symptoms and the placebo effect of the PCI in this cohort of patients. Again, Orbiter trial has been published before, but this is again a symptom correlation with the placebo effect of PCI. In this trial, the patients were given smartphone as well as survey to look into the how they reported symptoms. And interestingly, there was a very poor correlation between the patient reported symptoms and the severity of the coronary findings. Again, either the patient asymptomatic and they have very advanced disease, or the other way around, and then have very symptom, but really the coronary artery disease wasn't significant. Can be interpreted both ways, and this is the way I read it, is maybe they have some sort of Minoca or Inoca that is kind of contributing to this patient, or maybe endothelial dysfunction. That's why the symptoms were more severe, but angiographically not significant. And similarly, the other way, some patients can be well controlled with this medication, and yet they have severe disease. One thing was really important and to mention also, there was a strong correlation. Nature of symptoms powerfully predict the placebo-controlled efficacy of the PCI. Again, patients who underwent PCI felt much better after that. Again, good analysis of EuroPCR emphasized on the importance of optimal medical therapy and maximizing maximal medical therapy before intervention. Continuing in the coronary space, Pinnacle 1 trial looking into a new system for intracoronary or intravascular lithotripsy device, looking into patients with severely calcified, moderate or severely calcified coronary findings. In these patients, or in this trial, they looked into the efficacy and safety of this new device in patients with moderate or severely calcified lesions. Again, this is they looked into a cohort patient of 60 patients sequentially enrolled, and these patients have more than 90% success of the procedure and more than 90% success of the angiogram and intervention, and all of them has a good yield and has a good apposition of the stent. Obviously, it was done with imaging guidance, so it was good. Again, this is another option for IVL compared to the brand Shockwave that we use now or we have currently in the market. Again, this is another option, has a different mechanism, different scaffold, but again, maybe different sizing. In terms of deliverability, it wasn't commented much in the trial or when they presented the trial, but it sounds like the balloon is very deliverable compared to the Shockwave. Again, they did not compare it to Shockwave, but this is the claim came from the investigator. Staying again with the coronary is a very interesting study. Again, especially in the US, we have a new approval for DCB or drug-coated balloon for coronaries intervention. This Cage 2 trial is really looked into a cohort of patients who presented with acute coronary syndrome, meaning unstable angina, STEMI, and NSTEMI, who had balloon angioplasty only with a DCB. These patients, the study question is to de-escalation early of dual antiplatelet therapy for patient after DCB. So 2 arms. The first arm is traditional way dual antiplatelet therapy, which is aspirin and ticagrelor for 12 months. The second arm, which is more interesting, is the dual antiplatelet therapy for 1 month and then continuing for 5 months or monotherapy of ticagrelor, and then from there another 6 months with aspirin only. Again, DAPT for 1 month, then 5 months of ticagrelor, and then 6 months of aspirin. In terms the endpoint, the old composite endpoint of MI, bleeding, stroke, as well as myocardial death or acute myocardial infarction. No difference in terms of outcome as well as safety. So no less same bleeding as well as same efficacy in terms of thrombosis or vessel closure. Very interesting, powerful. Again, we are going into the space where DCB becoming more useful, but this is very interesting because it happened in a acute setting and we are de-escalating. So this is very important for patients who are high risk for bleeding. These are the older patient or the patient who are frail or the patient who have a poor compliance, or we have to interrupt antiplatelet therapy soon, especially dual antiplatelet therapy. Very interesting study. I really liked it a lot. Please make sure you take a look at it. Again, it's a cage-free 2 trial. Next is Revive BCIS2. This is the study the impact of complete revascularization in patients with low ejection fraction compared to medical therapy alone. These are patients who have low ejection fraction due to coronary artery disease. They compare complete revascularization using PCI compared to optimal medical therapy alone. After 2 years follow-up, there is no difference in outcome between these 2 groups. This includes rehospitalization for heart failure, developing heart failure symptoms, and or angina. Again, these patients did not have angina, but the purpose here is to see if complete revascularization would change the course of the heart failure or would change the readmission rate for these patients. As long as this patient on optimal medical therapy, they have done well. So this is again showing the strength and the power of optimal medical therapy and guideline diabetic therapy for patients with heart failure with multi-vessel disease. With again prolonged follow-up, 2 years, still doing well. Great study. Going back to the structural space, the SMART trial, as we know, the SMART trial is designed for patients with small annulus, especially in women, and comparing self-expanding to balloon expandable valves undergoing TAVR. These patients, this study was reported before, but now this is a follow-up study looking into specifically the woman cohort as well as any dysfunction or any change in hemodynamic, and comparing these two technologies. So again, after follow-up, there was, in terms of disabling stroke, MI, or any change in heart failure was the same. However, the hemodynamics and the outcome of patient undergoing self-expanding valve was better compared to balloon expanding valve. Again, this is a follow-up of the SMART trial, still holding and supporting self-expanding valve. Staying in the valve space as well, SOLV-TAVI is another trial, has a longer follow-up of 5 years. As a reminder, this is a trial that looks comparing balloon expandable to self-expandable valve in terms of patients who have high risk, comparing anesthesia type, minimal versus high general anesthesia, and also balloon expandable versus self-expandable valve. The outcome, as we know, is a stroke, pacemaker, heart failure, and perivalvular leak. At 5 years follow-up, there was no difference in the outcome between these two valves. Also, there was no difference in the outcome in terms of anesthesia type they received, but there was higher risk of stroke, minimal high risk of stroke in the patient who received balloon expandable valves. Again, longer follow-up, high risk profile of patients, more calcification. So I think that explains some of the calcification, the complication that has higher stroke in the balloon expandable. Maybe as we learn more, these patients will require kind of carotid protection or cerebral protection devices who are severely calcified and will undergo balloon expandable valve. Finally, is another structural and coronary study, is the transcatheter valve and coronary. This is a very interesting study and really shed a light on a very important aspect of the patient we see every day who have aortic valve stenosis as well as coronary artery disease. So in this study, they compared the outcome of patients with severe aortic stenosis and coronary artery disease who underwent SAVR plus CABG bypass compared to TAVR or TAVI plus PCI. This patient followed for 1 year, and the primary endpoint is the composite of all-cause mortality, MI, stroke, bleeding. Very interestingly, the surgery plus CABG, SAVR plus CABG, have 5-fold higher in terms of reaching the endpoint compared to TAVI as well as PCI. It was 4.4 in the TAVI group compared to 22.4 in the SAVR group. Very important discussion. Again, very important trial. It's important discussion to discuss with your patient as an option, especially in the intermediate and high risk, to undergo CABG as well as bypass compared to TAVI and PCI. Again, it wasn't clear, and also something you keep in mind is about the syntax score and simple or how hard it is or complex to perform complete revascularization in these patients. From the trial, the syntax score was comparable, but was on the lower side. I'm not sure if the syntax score was higher, how this will change, because we know surgery is better with a higher syntax score. But again, it's a very important study, kind of cover a big gap in knowledge about how to refer these patients when they have both problems, aortic stenosis as well as coronary artery disease. With that, I would like to conclude. Great 10 trials. Congratulations to the authors as well as the investigator. It was a great EuroPCR. Hope you enjoy seeing us. Watch these videos and others on the YouTube, as well as follow all the social media platform for cardiology update. This is Chadi Alraies from Detroit Medical Center.